Okay, welcome. My name is Michael Ivan, and welcome to the Miami Brain Tumor Symposium this week, June 17th, 2020. My name is Michael Ivan. I'm director of the symposium. I'm also the director of research at the University of Miami Brain Tumor Initiative and the site disease director for neuro-oncology at Sylvester Comprehensive Cancer Center here in Miami. My contact information, email, Twitter, and Instagram is here. If you have any questions about anything tonight or in past talks, please let me know. I'm also joined by my co-directors tonight, Dr. Komatar, who is professor and residency program director at the University of Miami. He's also the director of the UMBTI and the surgical neuro-oncology director. We have Dr. Morcos, who is professor and co-chairman of the department here at University of Miami. He's also the director of cerebrovascular and skull base. Dr. Benjamin is assistant professor. She is a brain tumor and skull base specialist and also part of the Department of Neurosurgery at University of Miami and at Jackson Health. We've had tremendous success. This is our 8th symposium. We have over 2,500 people signed up for these symposiums and over 5,000 views on YouTube. And all that success is really due to our great administrators, Christina Sotolongo, who's from the communications department at University of Miami, Ingrid Menendez, who's our amazing administrator director in the Department of Neurosurgery, Roberto Suazo, who's our graphic designer, who does all the flyers and the artwork for these, and Ignacio Escalona, who's here tonight managing our video production and making sure these broadcasts go well. So thank you to our team. If anybody has any more questions about the symposiums, you could always follow us on Twitter at Neurosurgery. All the videos will be posted at YouTube at the University of Miami Neurosurgery. There's 2 channels there, one for the Brain Tumor Symposium and one for the Skull Base Symposium and Cerebrovascular Symposium, or you could go to our website to click on Symposiums and the information will be there. We also have a cerebrovascular and skull base symposium that happens on Thursdays, same time at 5 o'clock. They alternate between skull base and cerebrovascular. Tomorrow's talk at 5 is featuring Dr. Gardner and Dr. Krish, talking about different approaches to the cavernous sinuses, either endoscopic or transcranial. It'll be a debate-like fashion, so I'm sure it'll be provocative and asking a lot of questions as to approaches for difficult tumors. So be sure to join them and their panelists tomorrow. And also a teaser for next week, next Wednesday, June 24th, we'll be welcoming Dr. Alonso, the chair of neurosurgery at Ohio State, who will be talking about von Hippel-Lindau disease and tackling hemangioblastomas via surgical approaches next Wednesday. So be sure to tune in. Just a quick comment on housekeeping to all our participants. Please use the Q&A button at the bottom of your screen to ask questions. We'll try to answer as many as we can throughout tonight. We want to make this as interactive as possible. We are not offering CME, but you will get an email confirmation documenting participation tomorrow. And please be sure to like, follow, and share our videos and upcoming symposiums on Instagram, Twitter, and YouTube so that we continue to share and educate the world on what these excellent and outstanding speakers have to say about neurosurgery and neuro-oncology. So let's get to this week. We have an outstanding group of panelists led by Dr. Hadjipanayas, who's professor in neurosurgery and oncological sciences at Mount Sinai. He's also the chair of neurosurgery at the downtown Union Square and Beth Israel sites, director of neurosurgical oncology and director of the Brain Tumor and Nanotechnology Laboratory, and also one of the leaders in 5-ALA here in the US. We have Dr. Adam Robin, who comes to us from the Department of Neurosurgery at Henry Ford Health System. He's also a brain tumor specialist, skull base specialist, and pituitary specialist. We have Dr. Pamela Jones, who is a neurosurgeon and brain tumor specialist from Harvard. She's assistant professor of neurosurgery at the Massachusetts General Hospital. And Brad Zachariah, who is assistant professor in neurosurgery, co-director of the neuro-oncology program, and brain tumor and skull base specialist at Penn State University. Thank you so much to our panelists for bringing some exciting cases to discuss at the end of the talk tonight. Our keynote speaker tonight, we're very, very excited. He's joining us late night from Germany, Dr. Walter Stummer, who is professor of neurosurgery, chair of neurosurgery at the University of Munster, and director of the program of neurosurgery at their hospital. He's also director of the Brain Tumor Center. He's past president of the German Society for Neurosurgery, and his special interests lie within brain tumor and vascular lesions. He's really the world leader in the introduction and implementation of advanced fluorescence-based diagnostic methods for neurosurgery. He developed the now widely used 5-LA method in collaboration with Zeiss and has many, many papers not only focused on using 5-LA in the operating room, but also with laboratory research as well. I'm sure he'll talk today about his phase 3 multi-center trial, which showed the clinical value of 5-ALA guided resection for malignant gliomas, not only just demonstrating improved resection, but also excitingly progression-free survival. So very, very excited to have him here tonight to talk to the world about his approaches in using fluorescence in brain tumors. So Dr. Tumor, thank you so much for joining us late night, and we're excited about your talk.
So thank you, Dr. Ivan. I hope everybody can hear me. Can anybody hear me?
Yes, we can hear you. So if you just
Right,
want to share your screen, you'll be all set.
I'll just start by sharing my screen. So yes, it is night here. I've had a hard day, but I'm really excited to be here. It's a great honor. I'm absolutely awed by, hold on. No, I'm still fighting here. By the number of people that are on here. Okay, can you see my, is this the right screen? Okay.
It's in the presenter, the speaker mode. We see both screens now. So if you just switch it on the top to presenter mode.
Better?
That's perfect.
All right, okay, thank you, sorry for that. So absolutely odd. I think the last count was 240 people listening. That's absolutely tremendous. So thank you very much. It's a great honor to be here. Give you the opportunity about talking about some of the stuff we've been doing lately with ALA, apart from just the fluorescence guide stuff. But for anybody that's not so accustomed with this, I'll go back to the basics and maybe take you to the future of this compound, which I think has a lot of potential. And what we're doing is not just the surgical part of it, but I hope I can get you a little bit of an impression. And so these are my pertinent disclosures to this. Obviously, this development over 20 years couldn't have happened with close collaboration with industry. Otherwise, this would never have been gone as quickly as it has with the approval in Europe and now also the United States. Okay, this is sort of where we started from many years ago when I was a resident still. And my former chief was a believer in resection, and 23 years ago, not everybody believed in resection of these tumors, but now we are all aligned on the fact that patients with malignant gliomas, as you can see from this, among many other graphs, this is actually from a prospective study that we did with the advent of radiochemotherapy, showing that if you do good resection for patients with glioblastomas, they fare best if you leave a little bit of tumor behind it, fare worse if you leave a lot behind it, fare even worse. And going from there, knowing that resection matters, we all know how difficult it is. If you see the subcortical glioblastoma here, and you open, the only thing you can really see well is the necrosis. It's really difficult to see which part is a contrast enhancing part, so the part of the tumor we're aiming at resecting. And more importantly, where's the function in all of this? So we've developed a lot of technology to handle this. And for finding tumor, it's, well, at least when I was working on this, it was ultrasound, navigation, intraoperative MRI. We all know the limitations of ultrasound in high-grade gliomas. It's a great tool for low grades, but in high-grade gliomas, it's really tricky with the edema, navigation of the brain shift, intraoperative MRI. So I don't know how many of you have an intraoperative MRI. We don't have one here. We won't have the money for that in the next future. But then it takes a lot of time, so excitement is not perfect there. And that's when we started developing many years ago ALA. And many of you are using this. I realize that now. I just want to point out a couple of things. Fluorescence, especially with ALA, is really a nice tool to have. We can see the fluorescence, gives us information in real time. So I'm saying real time. It's not, you don't have to stop. You just keep on operating, and the information is really unambiguous. It's really binary information. You see this red on the blue, and it makes it very easy to actually see what you want to resect. The bad stuff is the red stuff, so we like the colors. We chose them specifically for that because we all know, whenever you see red, it's bad. So that's why we chose these colors as they are. And this bottom video then shows you a little bit about the resolution we're getting with this. So it's a really tight resolution. You have this really small zone of transition with millimeter range. And the most important thing here is when we started out, was for finding residual tumor. over time we noticed that this is a much more powerful tool, because showing you very unambiguously where the tumor is, it gives you a strategy. So you find the red stuff. So this is a left temporal, this is a left temporal malignant glioma, and you're doing awake craniotomy, and you don't want to be worried about where the language is or where the tumor is. You have much more time listening to the patient doing his testing. So that's why this is such a nice tool to have. Okay, so nowadays, so we started this 23 years ago. I do realize that nowadays we're looking at a huge number of different ways that fluorescence is being exploited. Not to be confused with technologies such as Raman spectrography or OCT or confocal. There are some instruments available here. These are small field or narrow field tools which give you a sense of the microscopic composition of your tissue, but they don't give you this general field that we're looking at, this broad field kind of view that you're looking at with the fluorescence. So here's ALA, and so ALA is calling metabolic. I'll tell you why in a little bit. It's been around. It's the only approved substance at the moment. Folks have been exploring other compounds such as fluorescein sodium. Again, just to point out, this is all off-label at the moment. ICG is being used. I think from folks at Austin, Texas. This is Dr. John, forget his name. Talked to him last week. Anyway, and then there's a huge family of novel compounds, usually something with affinity to tumor cells and conjugated with something which fluoresces. And many of these are still experimental, but some are in transition, such as the APC analog, they're from Pennsylvania, and some of the others. So look forward to a number of very exciting developments here, which might overcome some of the limitations that we might have with the ALA. At the moment, ALA is really unique in that you're not actually giving a dye which accumulates in a tumor, but you're giving a prodrug. So you're giving something which is metabolized by the heme metabolism. It's actually the body's own drug, own compound in the heme metabolism, and you're giving it, you're bypassing the rate limiting step in this metabolism, and by giving it to patients or administering it to patients, and it's going along all these enzymes we all know from medical school. And then for reasons we don't completely understand yet, there's accumulation of protoporphyrin IX of malignant tumor tissue in the brain and other tumors of the body, and protoporphyrin IX is a very strongly fluorescent compound, and from its accumulation, it leads to very selective fluorescence, red fluorescence of tumor tissue if you have the right light source filter combinations for making that visible. So this would be a typical image from after you think a resection has been completed using white light microscopy. If you're very, very experienced, you might note that there are maybe a little more vasculature in this part of the tumor. But when you look at the fluorescence image of that, you can see the dark red stain, which is really unambiguous. And well, that's tumor. And we've been looking at this very, very closely, and other folks have been looking at this. I think are pretty unanimous about having understood or found that the positive predictive value, so how many of the tissue samples you take from this region actually contain tumor cells, this is in the high 90s. So I think, for daily life, it's safe to say if you're in this region and you see the fluorescence, then it's going to be tumor, and you can resect that. I'm not just saying don't heed safety issues here. So right next to it, you might even have a functional tract or a cortical region, which might be important. Now, the negative predictive value, or we're answering the question of, well, if you take a tissue sample from the non-fluorescent part of the brain, does it truly only contain normal brain? That value is very variable if you look at the literature. It's not perfect. It varies between 25 and 91% when you look at the literature. So some of our work, we were very conservative about this. We get about 25% taking samples here. So in about 75% of samples, you will still see tumor cells. So this is the biology of the tumor of a malignant glioma. It's going to spread for centimeters beyond in the brain. And it depends very much upon where you take your sample, what level of negative predictive value you're going to get. If you go far away, it's going to be much lower, of course. But that's the story. When you look more closely at this, and those of you experienced will recognize this. So this is a post-central tumor here being operated using a little bit of subcortical monitoring, of course. This all looks sort of the same, sort of healthy. White matter here at this stage, it still has this dark red or lava color. And as you move and resect all that, you go more for the pinkish parts of the tumor. So part of it is pinkish when you're going to the margins. We look very closely at that, taking a lot of samples from these regions in prospective studies, and found that if you're in this dark red part of the tumor, this is cell density here, this is the dark red, and the vertical bars are the median cell densities. So basically in this part of the tumor, you still have a median cell density of about 90%. And if you're resecting that and going to the pink part, then the median cell density drops down to about 10%. So by removing this and the pink, you're effectively reducing the tumor cell load by 1 log. And then you can still find tumor cells in the blue tissue beyond that. It's still about 10%. You can still see some fluorescence. If you can measure fluorescence, you can't see it anymore because we're only seeing the strongest fluorescence with our eyes, so we can't really pick that up. And even if you're further away, about a centimeter away, you still have about a tumor cell load of about 5%. So you're not going to get all the tumor, but the question is, do we want to get all the tumor? That's a different story, or every single tumor cell. To put this in a little bit more into perspective regarding what we are seeing compared to what we're seeing on the MRI. So this is what we're seeing out. This is from a Japanese colleague, Kaneko, from Sapporo. I need this lobectomy in this patient with this sort of circumscript tumor. And they're seeing here in the necrotic part of the tumor and the solid part of the tumor, which we can all recognize under white light. It's about 20 millimeters. You look at the MRI, it's 24 millimeters. So we're not seeing much of the contrast enhancing part. And if you're using the fluorescence, you're about 30 millimeters. So that means you're seeing basically much more of the tissue lighting up. And we know that, as I told you before, you're going down to about a tumor cell density of 10% when you get this region. Now you might say, do these couple of millimeters really matter in this patient, taking these additional couple of millimeters? And I will tell you that this makes a lot of tissue because you calculate the volume of a sphere by r to the power of 3. So it's actually a lot of tissue taking those couple of millimeters margin. There's another group that was working with this, looking at this closely, trying to calculate how much tissue are you taking in addition to what is actually gadolinium enhancing when you're just taking all the fluorescence. And this is a Swiss group, and they put together 13 patients, right? They resected all the contrast enhancing, all the fluorescing tissue. And before surgery, they measured the gadolinium enhancing part of the tissue. And then they measured the cavities, but obviously the cavities are not going to be a good measure because the cavities are usually going to be smaller than the resected gadolinium part because of the cavities collapse if you take away the bulk lesion. So they measured the brain around the gadolinium enhancing tumor and subtracted the CSF spaces and did that after surgery again. So just measured what is left of the brain after the surgeon has done his resection, and actually came up with a volume of fluorescing tissue, which is about double the volume of what you were seeing as gadolinium enhancing tissue. So that's important to understand that, you know, what we're seeing and we're probably targeting is less than what you would be resecting using the fluorescence in many, many cases. And specifically, if you plan this case, you might say, well, you know, this is a post-central tumor, and what can happen? I'm going to use monitoring for this patient. But when you see this image, you know you're getting into the sensory cortex, and you might want to consider some awake craniotomy for this patient for doing sensory cortex mapping and monitoring. So keep that in mind. Next question was, well, are we making a difference in the survival of this patient? These are some very, very old data here. One of the first publications was about 50 patients. If we resect all of the fluorescing tissue, does it really matter? And so we put together these couple of markers many, many years ago, so 20 years ago. And I found that if I was able to resect all the fluorescent tissues, tissue of these patients would tend to do best, followed by patients with some of the pink fluorescence left behind, so the infiltrating tumor, and worse, about 1 year median survival with those who left some of this dark red behind. And to put this in a teacup, the dark red is probably what we're seeing as contrast enhancing tumor on the MRI, and the pink is beyond. There's new data in support of the value of actually resecting all of the fluorescing tissue. This is some data from Spain. These are all patients, they came from a prospective study actually in immunotherapy. Study failed, but this Ricardo Diaz-Valle came up with some nice data on resection. And he has two cohorts here. The one cohort where he was able to resect all the fluorescing tissue, as opposed to the cohort where he left some fluorescent tissue behind. And all of these patients had complete resection of contrast-enhancing tumor, and you can see that these curves spread by about 10 months here. And so it appears that at least from these studies, you're probably making a difference in resecting beyond the contrast-enhancing tumor using the fluorescence as a signal. We looked at this more closely also. We used the FET PET signal as a surrogate for fluorescence. So this would be, resection after resection of a glioblastoma. There's some blood products here. The margin was there's no enhancing tumor left over, but we knew there was, for functional reasons, we left some of the some fluorescing tumor behind, and we did find a residual PET signal in these patients. And so we did a series of these, which was recently published, where we compared after surgery. We did a PET MRI, and we compared after surgery the residual gadolinium volume to the residual FET volume after resecting using fluorescence. So this is a little difficult to understand graph. I'll try to explain it. So what you have on the x-axis is here the gadolinium volume of the residual tumors, and here the FET volume on the y-axis. And so you can always see that you're up beyond the bisector here. You can always see that the PET volume is always larger than the gadolinium volume. So as I was showing you with the last slide, if you had resected all of the fluorescing tissue, so these are these blue spots, you were well in the range of small residual FET volumes. So FET is a little more sensitive than ALA. But you're well inside this region of tissue beyond the gadolinium enhancing tumor. So you're getting well into that area. And I found these data exciting because when we took that cohort and subdivided based on residual enhancement, we saw the effects on survival in this cohort. But when you took that curve with those patients which had no residual tumor on early postoperative MRI, and you stratified by whether they had a small residual, large residual PET volume, you again saw these effects on survival in these patients, and we're looking at 2.5 years here with 80% survival. So it appears that provided you can do this safely, you might want to consider going beyond the contrast-enhancing tumor, and there might be tools for this. So you might know this paper here from Ray Sabaya's group, I think 1,000-something glioblastoma patients. So basically his life experience, where he asked the statistician to correlate extensive resection with predicted survival, and they showed this curve where they show there's this good correlation of extended resection with survival. So curve sort of ends at 100% removal of gadolinium enhancing tumor. So what I'm saying here, and I think you've been hearing this a lot the last couple of years, maybe we can extend this curve, and some of the tools here might be LA intraoperatively, or use the PET signal, or diffusion tensor imaging, seeing the infiltrated part of the tumor, maybe flare imaging, but consider going beyond that, and ALA might be a good tool for that. And then having said that, the other part of it is certainly if you go too far and you create damage, you might be creating exactly the opposite effect for these patients. We all know that. We want safe surgery because, if you have a major deficit, there's some data here from Johns Hopkins published a couple of years ago, but it still holds, I'm quite sure. So these patients probably not going to have second-line therapies as healthy patients, in quotation marks, would have in case of recurrence. So that's probably the effect. So we have a special responsibility for these patients. As you all know, we're walking a very tight bridge here. These patients don't have time for rehab. They need to go to radiochemotherapy right away. They have little time for recovery or plasticity. So this is a different animal compared to a low-grade glioma. When you listen to Hugh Defoe, he goes to the very limits and he says, well, then you send the patients to rehab. But we don't have that with the high-grade glioma patients. Right, so you need to be careful that you're not just going to use fluorescence as a tool. So, this is our philosophy. We combine everything that we have, and the center of all this is still the surgeon that needs to know how to use these tools and to use them wisely. But don't just use one single tool. It's a combination. If I had an MRI, I would certainly use the MRI, and then combination, we can discuss that later. Okay, so changing to some of the newer stuff we've been looking at. And so many times the questions revolve around the low-grade gliomas, and what about the low-grade gliomas with anaplastic foci, which are not low-grade gliomas. So this is a case, rather large, first glance you would say this is a low-grade glioma. You do the FET PET, you can see there's a hotspot here. And actually, you biopsy the hotspot, you go in there, you see the fluorescence, and it turns out to be a glioblastoma, but there's no contrast enhancement here at all. If I told you it was 60 and you measured the tumor was more than 6 centimeters, you say, well, it's very likely that it's going to have a high glioma, but this was actually a glioblastoma. And so we tend to, and we've done a couple of publications on this, others have also, whenever we see a low grade, we think it's a low grade, and we see FET PET abnormality, and we'll go in there and see fluorescence, then many times that will mark or highlight an anaplastic focus. So basically, it's not a low-grade tumor, it's a high-grade tumor, and we'll go to the appropriate adjuvant therapy. Importantly, we still love the fluorescence for this because it helps us very nicely find that anaplastic focus and give that specifically to the pathologist, because the pathologist, you have to tell them what to look at. Just give them the big lump of tumor. You might just miss the pathology, and you might undergrade the tumor. So that's very helpful at finding anaplastic foci. But there's still a distinct subgroup of patients which don't have high grades or anaplastic foci and still end up. And we think you go in there and you think they're low grades. Some publications here which all have the same experience. Many times actually high grades with an anaplastic foci, but many times you also find, well, many times about 16 to 20%, you also find low grades which have some fluorescence. You take a sample from a fluorescing part and you give it to the pathologist. You think it's a high grade glioma, and he says no, it's still low grade. So we started looking specifically in that. I may remind you, this is of course off-label in the United States. So we're very generous at giving ALA to patients with assumed low grades if they have any form of an enhanced PET signal. I still seem to keep that in mind a little bit. So we looked at all of our low grades where we found fluorescence and gave that fluorescent tissue to the pathologist and asked him to tell us what it was, and he said, well, it's still low grade, even it doesn't, there's still fluorescence, but it's still low grade. And so we looked at some of these patients. This was an example of a patient with this insular glioma, and you see the FET PET signal there. You give the LA, and then this is the insula. You see some of the vessels. They have this greenish fluorescence, and you see hidden here under the cortex of the insula, you start seeing these patches of very nice fluorescence, and you give that to the pathologist. In this particular case, he did a big IDH stain. He saw no difference between the fluorescing and non-fluorescing parts of the tumor. He did a big stain in this particular case and was about 5%, regardless of whether it was fluorescing or not fluorescing. We looked at a lot of factors. Some of the molecular factors we're always looking at in these patients. The only thing that was sort of marginally different was that EGFR expression was a little bit enhanced in the samples taken from the fluorescing part of the low-grade tumor. So this might tell you something about the near future of these patients. Importantly, when you looked at survival curves or time to malignization curves and overall survival curves of these patients, you look here on the right, you can see the IDH mutation is certainly driving survival as expected in these low-grade patients. But also fluorescence status is driving time to malignization and overall survival in these patients. We're looking at about 4 years of median observation time here. And it turned out that these factors, at least in this cohort, were independent of each other. So there was no connection between IDH mutation and fluorescence. And you put all these together and looked at the individual factors. So looking at survival here, if you were a patient that happened to have an IDH mutation and no fluorescence, your survival is certainly best, and worst if you had both factors against you. And so we're looking much at a prognosis of a malignant tumor. And I find this observation very interesting. It was retrospective, needs to be shown on a prospective basis. When we're looking at low-grade patients, we're trying to figure out if we want to do very aggressive adjuvant treatment. And so we're talking about the high-risk low-grade patients, right? When they're beyond 40 years of age or have residual tumor, then they might go for radio and sequential chemotherapy. And sometimes we have a bad conscience with that, sending a young person to radio chemotherapy, knowing you might have 20 years to survive and maybe suffer some of the aftermath of that aggressive therapy, or other patients which might not want to send, and we're not sure about it. Maybe this might be an answer. We see some of the fluorescence, maybe that might help us discern those patients that are at risk as opposed to those patients which don't have such a high risk. Okay, so fluorescence finds residual tumor and high-grade tumor. It gives you a surgical strategy, as I was able to show, and it may be helpful in some of the tumors that we take to be low-grade, which are actually either high-risk low-grade patients or high-grade patients, which are hidden away as low-grades. So what's new? I want to get into this a little bit, and because there's a lot of activity going on with the meningiomas. Now I know many people here are probably, but you're also doing meningioma surgery, no question about that. So could it be helpful in meningiomas? You look at this meningioma, you know, there's no way why should this be helpful in meningiomas? But if you look at this tumor, this is a grade 2 recurrent, I think recurrent, resurgery, repeat surgery, radiotherapy kind of situation when you're going into this patient. And this is what you're faced with. I can tell you that this is the sagittal sinus, and you can see some of the bridging veins here, but then it starts getting really, really difficult to try to identify what is scar, what is tumor, what is brain tissue, adjacent brain tissue. And now I'm doing the markup here to give you an impression of what is brain, what is white matter, what is tumor. When you look at the fluorescence, you can see first that these tumors are actually very, very strongly fluorescent in many of the cases. And specifically, the fluorescence might give you very, very important information regarding the distribution of the actual tumor here, as opposed to some of the scar tissue and some of the adjacent brain tissue. It might help you in developing a surgical strategy and finding tumor remnants. And I don't want to get into any depth here. I just want to tell you that at this point, NX as sponsor is on the verge of opening it's a prospective multi-center blinded, so you have all the buzzwords in this. So it's a trial. For looking at the value of 5-LA for meningiomas. How can you do a prospective multi-center and especially blinded study in an intraoperative visualization agent? That's virtually impossible. So the solution here is actually to have blinded adjudicators. So we know that the surgeons are certainly biased when they do this kind of study. As soon as the fluorescence are completely biased, so you have adjudicators looking at what the surgeon is doing, and afterwards to try to figure out if the decision is truly based on a fluorescence rather than some other information. Okay, so that trial is going to be opening soon. It's seven U.S. centers and 2 or 3 centers here in Europe. Okay, that's just in the context of ALA for brain tumor surgery. Now I want to open a new chapter, and that is what else can you do with the ALA? We know that the fluorescence is one part of the protoporphyrin 9, so it's terrific for finding these tumors. But the protoporphyrin 9, so the fluorescent agent that develops or accumulates within tumor cells, is actually a very, very strongly photosensitizing agent also. So it was actually discovered in the 50s. ALA investigators were ingesting ALA and finding that they were getting sunburns because the protoporphyrin 9 was accumulating in the skin. Why were they ingesting? Because they were trying to unravel the hemoglobin metabolism. But that's a different story. But we know it's a photosensitizing agent, and so if light hits the molecules in tumor cell, it creates oxygen radicals, and that leads to tumor cell death. So that's very, very specific. Another form of very light, you might say, is also also photon radiotherapy. And so possibly ALA might also play a role as a radiosensitizer in these patients, and there's some data in support of that. So we've been specifically these last years been looking at ALA as a photosensitizing agent. So these experiments go back many years, where we show very, very nicely that you can get selective tumor cell kill if you these are animals, of course, restart rats, and you create these tumors. You give them ALA, and you hit the tumor from the surface here with light of sufficient energy and the correct wavelength. You kill these tumor cells. So that works in the animal experiments, and didn't take long with the experience we got from the fluorescence guide resection to start working on this in patients, using this in patients. So this was the first patient we actually ever treated many years ago. had this glioblastoma, was resected, a very young lady with 2 small children, and she developed this remote metastasis, which was treated with chemotherapy, radiotherapy. Nobody wanted to do surgery on this. And so this progressed, and so basically there was nothing left at the time. This was in the late 1990s. And so we treated this using ALA photodynamic therapy. So it's not as simple as just sticking a fiber into a tumor and giving light. So it's very sophisticated 3D dimensional planning we use. We use brachytherapy software for planning this, put the fibers in, and lit up the tumor for us with a specified amount of energy. And it turned out, this is what happened to that particular patient. This was the tumor before photodynamic therapy. This was 24 hours later. Basically, you can no longer see any perfusion. Then 7 days later, you have a lot of contrast enhancement at the margins, which is sort of disappointing. But this was basically only reactive, because that just went away and stayed away, and she survived very many years. And later she died of a complication of some of the chemotherapy she had before, lung fibrosis. So that appeared to be working. So we're still working on this now. At the moment, we're doing it more sophisticated. So this particular patient had this tumor. Nobody wanted to operate, and so I did radiochemotherapy. It progressed, so she had two regions of contrast enhancement, and this was the tumor before we treated it. And this is the diffusion weighted image I'll show you, because I want to show the changes that we do to this. This was the PET before the therapy. This was the image after therapy. I'm putting in a couple of fibers here, one fiber in here. So this is not laser-induced thermotherapy, right? There's no thermal effects in this. The laser isn't strong enough to create any thermal effects. It's just the light dose. When you look at the diffusion here, you can see that the diffusion goes beyond, so the cytotoxic edema actually goes beyond the original lesion. And this particular patient didn't want any other adjuvant therapy anymore, and she remained stable. Last time we saw was after 3 months. You can see that these lesions remain, the one sort of disappears, the other remains stable without any additional therapy. So this is what we're into now. That's all just single arm series that we did. We're now looking at a couple of trials here, and one which is a nightmare regarding regulatory matters. So we're going to start, I hope, with the next couple of weeks, because we have all the regulatory stuff in place, as actually randomized to be study with recurrent malignant gliomas. And then something else which might be the next step is basically when you're resecting a tumor and recurrent tumor, and you're placing the fibers into the cavity. And we have very high power, very modern laser systems, which we can use actually up to 8 fibers, position them strategically in the cavity after surgery, and treat those residual cells. And this should have been published by now. We call this open photodynamic therapy, or open PDT. And you can see the same kind of effects after surgery, with the fibers here in this very sensitive region here, where you just don't go for a very radical resection. You see this tumor remains stable 8 months after the surgery and the photodynamic therapy. Some survival curves, but one arm. And then finally, last not least, ALA and radiotherapy. I think is also an exciting new field. We certainly are not the first thinking about this, using ALA or ALA-derived porphyrins as photosensitizers. But here's some work with malignant melanoma and other tumors, which show that there's synergism between radiotherapy and ALA when you're treating these tumors. And in a situation when you have a malignant glioma, it's been operated on, had radiochemotherapy, and the tumor recurs, we'd like something which sensitizes the tumor to repeat radiotherapy. And I think this might be this is one of the next projects we're going to tackle after the PDT starts working. So last slide, ALA is firmly established. You might consider thinking about supramarginal resections using these tools and other tools. We're looking at other tumors at the moment, and there may be more in this than just the fluorescence guided resections. Having said that, thank you very much for your attention, and we'll go on with the panelists now. Well, thank you very much for listening.
Thank you so much, Dr. Stumer. That was really outstanding talk about everything present and future. We have a couple of questions that are coming up now. I think the overall question that I've seen a couple of times pop up is exactly which patients are you using 5LA for? I mean, obviously behind the high-grade gliomas, what is there specific for Mets? I think some of the questions are for any type of recurrences, for any types of tumors. What cases are you using 5LA for?
Okay, so we're using it in all malignant gliomas. We're using it in all low-grade gliomas where we have a FET signal. Again, reminding people that, you know, the use in low-grade gliomas is off-label, but you never know upfront, right? So we're very liberal about this because this has been around for so many years. But the situation is definitely different in the United States, so I wouldn't know how you would want to handle this, but just giving you the information. We're certainly using it in all recurrences, so we operate many recurrences. They still have focal disease. And from everything that we know in our experience, there might be some unspecific fluorescence in reactive astrocytes and some of gliosis, but certainly not functional brain. And if we do resection for recurrent tumors, I certainly believe in trying to resect as much as possible in those also. We don't have good randomized studies that prove that our surgery is of value, but if you want to do it, then remain within this logic and try to do it properly. We use it in childhood tumors, malignant epidermomas. Again, that is off-label. If they have astrocytomas, malignant epidermomas, our pediatric oncologists are very eager for us to use it to make resection as good as possible. Again, that is off-label. We're just starting a study in PEDs based on safety rather than large study with survival and so forth. That can really be done in PEDs. Metastasis, the story is not as clear. You have fluorescence about 70% of metastasis. You have some reactive astrocytosis in some of these tumors, which tend to show you unspecific fluorescence maybe. So you need to be a little bit careful with those. So I don't use it for metastasis. So we could, you know, there's a lot of hemangioblastomas, works very well. Not talking about the nodules, you know, those are simple, but sometimes you have these cystic hemangioblastomas where the walls are actually a tumor. So it works well in those. Again, all off-label use. But, you know, you always have the freedom to talk to the patient about this and use it because it's always been safe. You know, there's not toxicological issues here. But so you could go on for many, many hours about this.
Yeah, one of the other questions that somebody emailed me was any special techniques you use for tumors when you're working in a deep corridor, when you're having difficulty with the microscope light getting there and around a corner or up to the other side in order to ensure that the darkness you're seeing is not just lack of microscope light and it's actually lack of fluorescence.
So those are still some of the problems we're faced with, and you know, there's technological advances that are going to be in the near future, I'm hoping. So we also have an endoscope that does the same kind of light. It's important that it's the same kind of light. So this is not like you get buy a little laser at, you know, your hardware market. Blue laser, of course, gives you some fluorescence, but we know nothing about, you know, the specificity, sensitivity of the fluorescence you're getting. So you need to be careful with that, with blue diodes. So we're still using xenon light with special filters. We're lighting up the inside of the cavity. Probably you're gonna, well, you might want to try that, but you know, just like to warn people, we don't know much about the sensitivity, specificity, but we're using the endoscope. You can get that from one of the companies. And I know other people are putting diodes onto suckers and so forth, so that might be a solution to that. But that's still a little bit of a problem that we're faced with.
One other question here was, and I'm going to modify a little bit, is dosing of 5-ALA. Have you noticed anything with different ways to optimize, whether, you know, for pediatric patients or adult patients or for different tumor types, or do you always just go by the recommended weight-based dosing? Okay,
and that's an important question. You know, we're talking about so many different tumors nowadays, and if you look at the literature, everybody's sort of giving 20 milligrams per kilogram. Give that 3 to 4 hours prior to surgery, and I think, you know, for many of the tumors that might not be the optimal dose or timing. So it's something to think about, but you know, this should be done in the framework of studies, surely. So we're giving it 4 to 5 hours early. We came up with some data on the actual time course in tumor tissue, and turns out that the peak fluorescence is about after 8 hours, which doesn't mean you have to be at exactly 8 hours, but I would tend to give it earlier than later. I know that, so we say 3 to 4 hours prior to surgery. We always try to give it 4 hours prior to surgery. Now I know in the United States, especially, you have this problem with pre-admitting patients, and you have all those issues. We don't have those issues. We can admit them on the night before. So I wouldn't give it too late. We always give it with about 4 hours in advance. We have data on high doses. I wouldn't want to talk about those yet because they're still evolving. But just for your normal high grade glioma, for your normal grade 2 hidden away anaplastic focus, 20 milligrams are really sufficient for that. Meningiomas, I saw you these tremendous images, 20 milligrams. Probably from experiments that we've been doing many years ago, we're probably saturating your basic tumor cell with ALA with the 20 milligrams, provided it can get there. Okay, so it's probably not going to, in the glioma, it's probably not going to get much better. There might be some issues in the infiltration zone, but that's a different story. It's a completely different story.
Okay, great. Any questions from the panelists before we move on to the next part? Okay, Dr. Hajipanias, you want to start?
Yeah, let me share my screen. That was great. Thank you, Michael. Thank you, Rick, and all the panelists, and Walter, of course. Good seeing you again. Is that coming through okay?
Yep.
Yeah, it looks good.
Great. So, I'm going to talk a little bit, a case that we just did this past Monday to highlight some of the principles we just talked about, but also kind of highlighting the slide that Walter showed us, where we as surgeons have to make decisions with the data provided to us. So, I think fluorescence guided surgery has no doubt become a game changer in neurosurgical oncology. But just like with any tool that we utilize as neurosurgeons, we have to know when to stop. And I want to bring this case forward to the group to discuss. So here are my disclosures. So, this is the studies. We all know that, resecting as much of the tumor really helps patient outcomes. And this has been shown in meta-analyses. There's been other studies confirming that with gross total resection, better overall survival. But the reality is that when you look at many of the series, the majority of patients may not have a gross total resection of their tumor. And the reason for that is because of, maybe eloquent location of the tumor, better visualization. So FGS has really heralded the ability for the neurosurgeon to really see tumor tissue better. And this is a figure from a paper Walter and Ricardo and I did for our special issue in Journal of Oncology last year, where this kind of highlights all the tumor types. And I throw this here just because we were discussing which tumor types it's being used for, but certainly there are other tumor types that it's being investigated for, as you see here, and then photodynamic therapy is a new area that we're studying. So this case here is a woman who actually came to us in the height of the pandemic here in New York City in April with who was thought to have had COVID. And she was actually admitted into our COVID unit for observation. And she was quickly found to have speech difficulties, right-sided weakness, and then an MRI scan was obtained showing this, nasty looking tumor. She's right-handed, dominant left frontal parietal tumor with significant mass effect, edema, etc. So because of our situation at the time, we we had no ICU, we had no PACU. We were really limited in what we could do, and we ended up just doing a biopsy on this large tumor and placing the patient on steroids to really, kind of get her through and get her to her adjuvant therapies of radiation and chemotherapy. Her biopsy did reveal glioblastoma. It was IDH wild type. It was unmethylated. And it turned out she didn't have COVID. She had a follow-up CT. Her chest was okay. And she had testing, which turned out to be negative after 3 times. Unfortunately, as we know, with any tumor this size, these patients just don't do well. I mean, we know the natural history for a large glioblastoma tumor that goes on to radiation and chemotherapy. The edema, the swelling from the tumor growth and from the adjuvant therapies are going to get the patient in trouble. So this patient bounced into the ER multiple times in May. After she finished her radiation therapy, she was on high-dose steroids, starting having side effects of the high-dose steroids. And then, of course, this past week, things really crashed, and she was not moving her right side well. She was very confused. And, we admitted her and got this new MRI scan. So this is the scan that was just done this weekend, and you can see that that large tumor didn't go away. It's still there, and there's more contrast enhancement, holohemispheric edema, as you can see. So this lady we took to the OR on Monday, and this is kind of our planning system we use just to look at whole brain tractography. And while you can't see the tracts on the left-hand side because of the edema, you can see the cortical spinal tracts and other tracts on the right-hand side. And based on the tractography, we knew this tumor was kind of nestled in the motor cortex with displacement of the tracts anteriorly. So this is a picture from Monday where I mapped out the motor cortex. You can see the big T is for tumor. You can see some the microvasculature of the tumor, which kind of extended almost to the peel surface, and face and arm are right there, kind of right next to the tumor, and we knew this tumor kind of undercut those cortical spinal tracts. So this is a great case that I feel that fluorescence-guided surgery in combination with intraoperative monitoring is quite helpful, because we're trying to get as much information as we can as neurosurgical oncologists so we can really make a decision in real time for a patient. But ultimately, we have to keep the patient in a safe with a safe decision. So here's just some more pictures, just cauterizing the peel surface. And just how close it was in involving those motor pathways. I use an exoscope for all my tumor resections, the Synaptive Modus V, and you can see this thing is just a vascular, nasty, sticky tumor. This is deep in the cavity, and I'll show you the fluorescence-guided surgery. You can see thrombosed vein right there, and just along that anterior medial portion of the tumor, that was the part that we know is really kind of intermingled with cortical spinal tracts. And the question is, what do we do? Do we go after all this tumor? And certainly I took out as much as I could with conventional light using the exoscope. And you can see how beautiful the view is. Visualization is quite nice, able to perform good hemostasis. I debulked the posterior part of the tumor quite well. And then we finish the resection. I do as much as I can with the exoscope, and because my exoscope has no fluorescence filter at this time, I then bring in our Zeiss microscope, and then I do, and then I do the fluorescence guided surgery. So one of the things I want to highlight, and we're actually getting and Adam, I think, is helping us with this, we're getting our series together where we're looking at all our patients who got 5-ALA, basically over 5 hours prior, and looking at fluorescence. And as Walter stated, those tumors fluoresce really well the longer you wait. And there's anecdotal cases where it's been over 24 hours. But, we're actually waiting at least 6 hours for all our fluorescence-guided surgery cases now. In this case, it was over 5 hours. And actually, by the time we got to it, it was 6 to 7. And you can see here, so that posterior part, hopefully my cursor's coming through here, but that posterior part's got the pink. And then under and in the cortical spinal tracts, you see that lava red Walter was talking about. So, I did map things out, and that's all eloquent tissue. And, the question is, how far do you go? And I would argue that the lava tissue represents malignant tumor tissue with dense cellularity. I think as we get into the pink tissue here, we are going to be involving tracts. And I think, the decision that we made at this point after I resected that lava red was to leave behind that pink tissue anterior medially. This lady's motor evoked potential stayed stable, but there's no question that I was right in there, right? I mean, look at where we were, where I mapped it out earlier, and how we're undercutting into those eloquent fibers. So this is where I think we need to be very careful, where we don't just go in and take out everything that's fluorescent and beat our chest and say, oh, we got it all out. We got to be really careful here with this technology and moving forward. So, I got a post-operative MRI, and there's a little bit of blood in the cavity. She actually did fine. She is weak, for sure. She's definitely weak, and I'm hopeful she's going to get better. But, this area here, along that medial centrum semio-valley area, there's some contrast there. That's, is that tumor? Is that tumor/treatment effect? So, this is where the discussion, I think, is important with tumors involving those motor pathways. Knowing when to stop, I think, is important. And we have to really kind of pay close attention to that and utilize the technologies we have. Intraoperative monitoring helps us. If you use intraoperative MRI, that can help. But remember, intraoperative MRI is only one snapshot. It's not a real-time image guidance, because you're just taking one picture and then taking the patient back out and operating. And then again, the other thing that we need to keep in mind is with GBM recurrence in patients who've had radiation and chemotherapy, we do know that there's some Japanese reports and others that, you can have some, reactive fluorescence around the tumor related to the treatment effect. So that's something to keep in mind too with some of these tumors. So I throw it back out to the group, and I thought this is a timely case and kind of represents all the challenges that we're going through here in New York City to you guys, and maybe Pamela's on there too. But love to get your thoughts here and see what else you can think of. Maybe Walter, you could provide some thoughts too.
Yeah, certainly. Well, tough case, right? I mean, we get these cases. Sometimes know what to do. I would never do this if you didn't have adjuvant options, but she still has the whole chemotherapy arm in front of her, right?
Yeah, no, she's getting Temodar.
Right.
She's unmethylated, and there's an argument whether she should even get Temodar, but I think it was just started because we had really nothing else to give her during the issues we had.
I think that looks like a great resection, especially given what you were finding in surgery. I think when I'm using 5-ALA, I really use it as a visualization aid. And if I'm doing a tumor that's near eloquent cortex, I do it awake, or I let the asleep subcortical mapping tell me what should come out and what shouldn't come out. And I've had several cases where we're able to utilize stimulating suction. While you're chasing, I think the technologies are really complementary. They really synergize, I think, to get an optimal resection. You're chasing tumor near the subcortical fibers, and you get up to 3, 4, 5 millimeters away. And a few times it's been the last bit of a strongly fluorescing tumor, and it's very satisfying to take that tumor out while managing to stay what I think is about 5 millimeters from corticospinal. And sometimes I leave some of that tumor behind, just like it looks like you may have done, whether that's treatment effect or tumor in this case. And so I think they're very complementary. Yeah,
Great points, Adam.
Yeah, I mean, I think this is is a great result for a very difficult case. It brings up a couple interesting points. I mean, I think if this was a low grade, I think there would be no question, to stop and then hopefully wait for things to reorganize and maybe go back a later time. But because it's a high grade, it's so frustrating to see that fluorescence in an area where you can't get to. Highlights that question of where this PDT ability to kind of use the 5-ALA that's fluorescing beyond where you could get surgically. How do we use that to our advantage, and to try to kill that tumor? And so I think if the PD trial eventually comes over here to the US, this would have been another great patient to kind of do an adjuvant addition to that.
Yeah, what's interesting is the French, they've completed, and Walter knows this, the French have completed their phase 1 study with putting an intraoperative balloon in the cavity and then illuminating the resection cavity for intraoperative PDT after FGS. So that's another, option that I think we're going to potentially have here in the US either implant, laser catheters or put a balloon in for 20, 30 minutes, and then you're done.
Yeah, we just finished. We have some laboratory work that's getting published later this week. That's looking at this combination of PDT with chemotherapies and how to kind of exploit the synergistic abilities of different kinds of chemotherapies with PDT with 5-ALA. And so that you bring up a point that this patient's already on chemotherapy and radiation. You did the resection after that. Is that better for the patient? Because it's being done after treatment, or what goes first, and how is that going to work? I think all questions that will need to be teased out in the future.
Yeah.
Okay, let's go with Adam. You want to fire up your slides, Adam?
See if I can get in here. Can you see that okay?
Yeah, I just got a presentation mode. You'll be all set.
Let's see.
That's
So this is a really short case. Let's see if I can move this out of the way. Give me 1 second. I can't get that. There we go. Dialog box out of the way. Good. All right. Sorry about that. So this is a really short case that's really, less of a technical challenge and more sort of proof of principle. I think, Kostas, you were talking about cases where anecdotally we see some fluorescence after about 24 hours. And this is one of them. It began with a gentleman who came in, was transferred down to us from northern Michigan, and had about 6 months of progressive clumsiness, weakness, and numbness in his right arm. And started having, episodic exacerbation, consistent with seizure activity, and then finally had a generalized seizure and was found unconscious and lethargic at home. And after treating him, he came in and had an MRI that showed this tumor sort of in the central region that had some cystic components, some enhancing tissue, and also some T1 hypointense and T2 hyperintense component to it. You can see on the sagittal there, it's really right in or near sort of ventral premotor area. There's a superficial component to it, which seems to be enhancing and comes near the surface that you'll be able to see, I think, on the coronal in a second. And, this is a patient that, we would treat with an awake craniotomy so that we could identify primary motor and somatosensory. So this was early on in our 5-ALA experience, or in my 5-ALA experience. It was around 2018. We talked to him about 5-ALA. I think we did this case as part of a trial, and we give him the standard dose that we've been talking about. We planned on administering it 2 hours ahead of our scheduled OR time, which would put us probably around 3 or 4 hours out from the time we'd be getting down to the tumor. About half an hour before we were scheduled to head back to the operating room, he developed a fever and actually felt feverish. So he came in at 38.8. We watched it for a minute, and his fever went up to 39.4. And I'm wondering from the other panelists or people that use this a lot, how frequently you see this kind of pyrexia before surgery, and what you do with that scenario.
Yeah, we really haven't seen fevers like that in our patients down here, but I'm not sure if anybody else has.
Yeah, it's a well-known side effect. It's rare, but it happens. I mean, it's one of those ones. Fever and hypotension can happen. Actually, the UCSF group has had some issues with that with the non-formulary 5-ALA agent, but I think it's rare.
So what do you do? So in a patient like this, would you proceed with surgery as scheduled?
I think so. It's a transient type effect. I don't think it's anything permanent. It's just kind of a reaction for some reason. A fever is elicited.
Okay.
But it's rare. Walter,
I think.
yeah.
Oh no, go ahead. Yeah.
We did, and we closely monitored up to 500 patients. Actually, we never actually saw that. So, keep my eye open. We never really experienced that. We did look very, very close at toxicology, and this was always, in the phase 3 study, this was one of the focuses, of course. If you have something which just helps us as a diagnostic agent, has to be safe. So I wonder, were there any other systemic effects, CRP increases or something, procalcitonin? Did you look at that?
We didn't look at procalcitonin. No, we probably should have in hindsight. But my sample size for 5-ALA cases when this happened was about 6. And so, for me, I spoke with anesthesia, I talked with the patient, and we decided we were going to defer surgery for that day. And then we sort of worked him up with some other, inflammatory markers. You had Dopplers done, chest x-ray. It was pretty self-limiting. In fact, the fever had abated, I think, by lunchtime and didn't come back. There was no treatment. And so, after a discussion, we decided we were going to do surgery again the next day. I think the earliest we could get into the operating room was around 9:30 or 10 o'clock. So that's, that's already about 27 or so, 28 hours or so after administration. So just to recap, 5:50 a.m. the day prior, we gave the dose, standard dose. We wound up making incision close to noon, so we're close to 30 hours now out from the initial administration. And then I sped this video up, but we wound up doing our mapping, finding that the tumor was basically pushing the motor area out of the way and was sort of located in primary somatosensory. We wound up not being able to take out the non-enhancing portion because every time we stimulated, the patient had terrible dysesthesias. But we could get away with this resection, which you can see is exhibiting real strong fluorescence for us in that superficial portion of the tumor until we popped the cyst in a second, without causing any problems for him. And so eventually, we cleaned up all of the strong enhancement, as you might expect. You can see that, sort of on the bottom of the resection cavity, you no longer see any enhancement there. That was actually the area that was T1 hypointense and T2 hyperintense. And then that's just after we took out the cystic portion, we don't see any more enhancement anywhere. And I think everyone who's probably watching this video is pretty familiar with that real pale color that you get once you're done with your resection and all the enhancing tumor is out, maybe beyond, as you were talking about, Dr. Storm. So we did have to leave a little bit of that T2 hyperintense tissue behind, just because I think that was situated in sort of an infiltrative fashion right in primary sensory. But otherwise, we were able to take out the enhancing portion of the tumor. It was an anaplastic astrocytoma. It was IDH wild type, and was methylated. So, this gentleman's still doing well. There hasn't been much in the way of change. There's been some, after radiation, there's been some sort of, ebb and flow to some peripheral enhancement around that other area that we didn't resect, but it's mostly gone away now, and all of our perfusion imaging suggests its treatment effect. So clinically, he improved and has been doing well and is spending most of his time fishing these days. So I think, we know that there are certain things that may affect 5-ALA metabolism. Phenytoin, maybe hepatorenal dysfunction, although I haven't seen anything that definitely shows that. And I know, Dr. Stummer, you were talking a bit about various molecular alterations and or mutations earlier. Is there anything else that you think may play a role in why some tumors might fluoresce all the way up through 32, 33 hours like this tumor did?
Well, I've we never actually operated on a tumor later than 24 hours. The only one that we did had a weak fluorescence the next day. We stopped doing that. That's a really interesting case. food for thought. Maybe because it's an anaplastic astrocytoma. Was it? You said it was IDH wild type, right?
Yes.
Mm-hmm. No, I wouldn't have an explanation. That's interesting.
Would you have maybe considered redosing the morning of?
Yeah, we don't redose the next day. There have been reports of people doing that. It hasn't led to any major toxicity or anything that's been reported. We usually wait 1 or 2 days, look at the liver enzymes if there's any problems. So this is a really unique case. Maybe we're thinking, well, maybe it's just a grade 3. We did our exams in grade 4 basically, and we found the peak after 8 hours. Maybe grade 3 is behaved differently. I don't know.
Okay, good, thank you.
Yeah,
But
also,
you know, just get back to the fever issue. I mean, I really wonder about that. So there was nothing else that is special because I can't remember seeing this ever, and I don't think I think our anesthesiologists are equally attentive as yours are. I mean, if there's anything wrong with the patient, they will say immediately. So maybe you're doing something completely different in the ocean. I have no idea, but this, you know, really interesting.
Yeah, no, we couldn't find, we couldn't put our finger on anything, that was untoward. He didn't come in with any pre-existing illness that we could find. I mean, we sent a whole viral PCR panel. His liver enzymes were normal coming in. No major pre-existing illness. So I don't know. He had a fever and we administered ALA. True, maybe related. I'm not sure, but we did see the fever.
Generic. This is original field on ALA or not?
Yes.
It's just okay. Okay, maybe we can just follow up after offline at some point.
Sure, absolutely.
okay, Brad. While Brad's firing his slides up, the question is also on the opposite side, Adam. How long then do you keep the patient in low light after this, knowing that sometimes people metabolize this at different time periods? Are you using 48 hours or using longer? What's your protocol?
Yeah, we're using 48 hours. The powers that be in our hospital are pretty stringent. And I actually had a question for the other panelists related to that. I can barely see the patient half the time when I go into pre-op or when I'm rounding on, the morning after surgery because things are pitch black. And, I have all of our wonderful nursing staff and everyone else telling me, no lights, no lights, no lights. And I think sometimes there's more danger in that than there is with some low-level ambient light. What is the protocol in your hospitals, and what has been the experience?
Yeah, in our multi-center study you guys were part of, we had a couple photosensitivity reactions, but I think, having used it now for a couple of years, and Walter, he's obviously the guy who's done it the longest, but I think the trouble where we get into is in the OR with the OR swivel lights and those really bright lights. And what I do is when a patient comes to the OR, I turn the swivel lights off until they're draped. It doesn't mean you can't have the standard OR lights on. It's just those bright lights, I kind of either angle them away or turn them off and then use them during surgery. I don't think lights in the ICU or lights in the PACU area, I don't think those can cause the photosensitivity. I may be wrong, but I have not seen it from that. We did a couple of wakes when I was down at Emory. One, I remember, and I used that clear, transparent drape for awake craniotomies. And that patient ended up having, that bright red skin photosensitivity on their head afterwards. And that kind of tipped it off that, those bright lights may be the culprit.
Yeah, I had a patient in the trial who, this was, I think, post-op day 1. He just kind of went and kind of hung out by the window for several hours, kind of looking longingly outside. And again, I think just mild kind of skin irritation and sunburn. But yeah, Adam, same thing. I mean, I think we encourage people to minimize the light, but I think we certainly have no problem with the ambient light. And I think it's more that focused kind of bright light that's probably the issue.
Yeah, same thing in South Florida. We're always very sensitive because we have a lot of sun down here, not to brag or anything. But yeah, and a lot of our patients do go home on post-op day 1. We've been keeping all of our 5-ALA patients to post-op day 2 and discharging them. And so far we haven't had any issues, and we're looking at ways to kind of go back to post-op day 1 discharge for fibrillate patients.
Well, you know, the FDA label is 48 hours, but when you look at the skin photosensitivity, it's usually within the first 12 to 24 hours.
Exactly, yeah.
So.
Well, that's very helpful. So I'm not crazy. Thank you.
All right, Brad.
Yeah, so this is a very short case, just to kind of illustrate one point and to get Dr. Stumers and everybody from the panel's input. It's a 59-year-old gentleman who presented with some cognitive difficulties, word finding issues, and some mild left hemiparesis. He's again left-handed. Had this fairly classic right temporal enhancing lesion. He underwent initial resection. This was an IDH wild type unmethylated glioblastoma. He unfortunately did not pursue adjuvant chemoradiation. Not surprisingly, represented about 6 months later. This was recently, just earlier this month, with an obvious recurrence. And again, at this point, had acquiesced and said, he was willing to undergo adjuvant chemoradiation. He had tried some holistic treatments that his family had kind of discussed, but wanted to go in with a fresh resection. He had developed some worsening hemiparesis, kind of higher cuts of the MRI showed this kind of inching, towards the midline structures and kind of causing some compression on the internal capsule. Again, had some mild aphasia, had done this awake initially and then recommended a follow-up awake. Just draw your attention to the sagittal image and seeing that kind of linear enhancement along the ependema that you sometimes see with these glioblastoma. And so this is just a very brief kind of, we did the temporal lobectomy without fluorescence, and then brought this in at the kind of latter portion of the resection, really the cleanup. And this is just highlighting we're inside the temporal horn. This is basically the caudal aspect of the ependema, the kind of the roof, essentially the hippocampus here. You're able to see in both the still and the video kind of the very bright, that lava red fluorescence fades out to pink, and then almost a clear demarcation within the ependema area where you see that more blue kind of non-fluorescent tissue. And so he ended up with a nice resection. We removed that fluorescing part of the ependema. And I think I just bring this up to highlight something that I know Dr. Stumer had published on recently, actually, and there's been a couple kind of publications about this, but I think particularly important for those who are just starting to use this, because I think this is one of those areas of potential false positivity of enhancement. And so, how common is this ependymal fluorescence, both in the presence of true tumor and in the absence of tumor, kind of the sensitivity specificity question for this specific type of enhancement. I know Dr. Stumer's spoken about this diffuse versus focal enhancement. I mean, clearly if there's a single focus nodule of enhancement within the ependema, that's likely tumor tissue and may warrant resection, but I've often found, that you have really diffuse ependymal enhancement. What's the etiology of that or the pathophysiology of that? And again, does it impact prognosis in the absence of there being tumor there? Does it signal something in terms of that ependema or the way that tumor's growing? So again, just something that I've noticed, again, only having started using this over the last year or so and doing more and more cases, something that you see frequently in both cases like this with what I believe to be true ependymal tumor, and in those cases without real frank tumor. So just interested in kind of other people's experiences with that.
Right, maybe a couple of words from my side. So my world, if you see this ependymal fluorescence in a de novo glioblastoma, no treatment, from everything that I know that we've investigated, I'm quite sure it's always going to be infiltration. We see that absolutely, that distinct margin that you were showing right now. So that's pretty clear. But in the recurrent setting, when you have a tumor that's been pre-treated and you have maybe the influence of the radiochemotherapy on the ependema, you can see the clear hyperintensity many times on the MRI. In those cases, I think will light the ependema will light up, and we know we don't like to operate in the ependema with the adjacent tracts and so forth. In those cases, I will not chase that in the recurrent cases. So that's sort of how I live this. But it's certainly something that needs to be investigated. I remember one case that was published from UCSF where there was this case that had temporal glioma and occipital recurrence and was connected by this route of fluorescence, and it's a thing about the subintimal zone and the stem cells and so forth. So it's something we're looking into. It's a conundrum at the moment. I think for practical purposes, if it's a novel situation, it's going to be infiltration. And I would always be careful in the recurrent tumor where you've had epidermal damage, maybe based on the radiochemotherapy, but it's something that definitely needs to be investigated further. I know if the others have any similar opinions or experience with this.
Yeah, I mean, I've seen it once or twice before as well, Brad. I just, it came back positive for tumor, but it was very interesting to kind of open up the ventricle and then see that fluorescence kind of light up. You know, it's always questionable with the enhancement on the MRI, what you're going to find there, but I agree. More data needs to be done to figure that out.
Yeah.
But great case. Nice job. Okay, great. Well, I think that concludes everything for tonight. Pamela, unfortunately, was tied up in emergency, but thank you all for joining us. I really, really appreciate your time, especially Dr. Stumer coming late nights. Thanks for staying so late for us. I appreciate it.
Yeah, thank you.
Yeah, thanks
Great,
to all.
Walter. Good night.
Take care.
See y'all. Good night.
Bye, everybody.
Take care.